All right. So I'm going to get started just by talking very briefly about cancer survivorship. Jennifer and Stephanie will be getting into this more in detail in their part of the presentation. So first of all, what is a cancer survivor? What is survivorship? Canadian Cancer Society's definition is essentially an experience of living through or beyond an illness. In our experience, different people define cancer survivor in different ways. Many people refer to themselves, of course, as a cancer survivor. But some people who have lived through cancer diagnosis and treatment don't refer to themselves as a survivor at all, while others who are, for example, diagnosed at a later stage or who have metastatic cancer don't believe that they are survivors, but are instead living with cancer. So according to the Canadian Cancer Society, there are approximately 1 million Canadians who have survived cancer for over 10 years. And although this is a success story that has come about through better early diagnosis, better treatments, it's also a reflection of just how many Canadians have been diagnosed with cancer, which has risen to nearly one in two individuals in Canada. With more cancer patients surviving, there's a need for specialized services to help survivors deal with the at times debilitating side effects of treatment and the cancer itself. And this is why we link survivorship and rehabilitation in all of our discussions. Many Canadian studies have demonstrated that lack of access to timely information and support for survivors is prevalent across our country. Survivorship issues related to the long-term physical, psychological, and emotional impact of cancer and its treatment seem to not be as important in our provincial healthcare systems as the treatment itself. So in the past year, CCSN has been taking on a number of initiatives to raise awareness for survivorship and rehabilitation for cancer patients in Canada. I'll only be touching really briefly on each of these initiatives for the sake of the presentation, but I'll include some links in your follow-up emails tomorrow about some of these events and initiatives in case you'd like to learn more on your own. So it began with our first All-Party Cancer Caucus in Ontario in November 2017, in which patient representatives and MPPs met at Queen's Park to discuss the gaps in cancer rehabilitation. We were joined by Dr. Sarah McEwen, a scientist at St. John's Rehab Research Program's Sunnybrook Research Institute and an assistant professor in the Department of Physical Therapy and Rehabilitation Sciences at the University of Toronto, who spoke on the effectiveness of rehabilitation and the lack of access for cancer survivors. And then following that, in March 2018, we returned to Queen's Park to continue this discussion, again with MPPs, patients, caregivers, and medical representatives. We also met with representatives from Cancer Care Ontario to learn about how they are implementing rehabilitation. We were joined at this caucus by Dr. Jennifer Jones, who's one of our two presenters for today. You can see her in that photo on the right speaking to everyone, who discussed her program and research, which she will be going into in this webinar. And we were also joined by Colleen Dunphy, Interim Manager for Collaborative Practice and Education at St. Michael's Hospital in Toronto, who spoke of the lack of training and competencies to provide cancer survivors with rehabilitation specific to their needs. Our third caucus took place in Alberta. It was our first Alberta All-Party Cancer Caucus. So we invited, again, MLAs from all parties, our patient representatives, as well as Margaret McNeely, who is a physiotherapist. CCSN Head and Neck Cancer Advisor Sharon Dixon spoke about her troubles as a 12-year cancer survivor, expressing a need for better psychological and psychiatric services for those dealing with the hardships of recovery. And with all of this valuable information from our three caucuses we had up until then, we ran a successful survivorship survey over the summer, which we'll have the results for soon. And we also launched a new survivorship and rehabilitation section on our website, which is pretty detailed, and I will include a link to that in your follow-up emails as well tomorrow if you'd like to have a look at it. We're also currently developing an advisory council on survivorship and rehabilitation, and we're preparing for our third Ontario All-Party Cancer Caucus on survivorship and rehabilitation this coming November, exactly a year after our first caucus, which kicked off this entire initiative. So if you'd like to be kept updated on our survivorship initiative, don't hesitate to drop us a line at any time. Our contact details are included in the follow-up email as well. I'm going to turn it over now to my colleague, Director of Public Policy at CCSN, Jaymee Maaghop, for the next part of the presentation.
Thanks for that, Allison. So hi, everyone. I'm the Director of Public Policy for the Canadian Cancer Survivor Network, and I will walk you through the availability of oncology rehab programs in Canada. So The main point here is that the amount of rehab programs for patients currently receiving or have undergone cancer treatment is scarce. So in 2013, the University of Toronto examined the availability of oncology rehab programs for people living with the symptoms of cancer and its treatments. It was the first study of its kind in Canada. Now, in the following slides, you'll see a lot of numbers and etc., but I will go through and explain the data they gathered. So the researchers started by searching for contact information for hospitals, private clinics, and community-based programs. They identified 179 health centers and heard back from 116. Now, with the 20 health centers, from the 116 health centers here, 62 completed their survey. From the 62, 41 did not have a formal cancer rehab program, while 20 health centers did, and one was unsure. Now, with the 20 health centers that self-identified as having a formal cancer rehab program, 15 of them were located in urban centers. That means only 5 were in rural locations, and this is across Canada. Again, this is the first study of its kind, and there has been a slight growth in research and investment for cancer rehab programs in certain provinces since then, and I think Dr. Jones will say more about this in her slides. And in addition to the small number of services they found, the researchers concluded that there was no database available for cancer rehab programs. This makes access much more difficult. However, I do want to point out that another study, let's see here, over here, another study conducted by Realize Canada saw that publicly funded and or community-based rehab services for chronic diseases, including cancer, are lacking for people aged 18 to 64. Why? This is because most of the programs available were for residents in long-term care homes or palliative services. But not all patients and survivors want to live in these conditions. Many want to continue life after treatment. They want to go back to work. They want to care for their children and families. So concluding my part of the webinar here, there are 5 key things to take away from the information us here at CCSN found, especially from what was discussed in our all-party caucuses. Number 1 is that rehab is mostly available for residents in long-term care homes and for other diseases. And rehab after treatment is not often considered in the cancer care continuum. Patients are on their own to deal with the long-term side effects of cancer treatments. There's no database that exists for cancer rehab programs in Canada, and there are no defined credentials for a specialist in cancer rehab. So a physiologist may say that they have experience with treating cancer patients, but in reality, a breast cancer patient or survivor will have different needs and symptoms than a breast cancer patient or survivor with bone mets, for instance. There is work being done in some provinces to address this, but they are mostly in the early stages of development. We now know that Alberta is one of the leading provinces in developing education and training curriculum for healthcare professionals. And again, Dr. Jones and Stephanie will probably have more to say on this, and that's it for me.
Awesome. Thanks so much, Jaymee. So with that, I'm going to turn it over to our main presenters today, Dr. Jennifer Jones and Stephanie, who will speak more about what they do and the importance of survivorship. Ladies, you can go ahead at any time.
Wonderful. Thank you so much. It's our pleasure to be here today to share with you what we're doing here at Princess Margaret. So what we're going to do is I'm going to start by just presenting a little bit of background, which leads to our program, and then Stephanie will jump in and provide an overview of what we actually are doing here at Princess Margaret, and I'll finish up talking about some of our future directions with our program. So next slide, please. Okay, and next slide. So this just provides a little bit of background, and I'm sure most of you are aware that we are seeing an increase in the new cases of cancer being diagnosed across North America and certainly in Canada. So in the next 2 decades, we're expected to see a rise of over double the amount of people diagnosed with cancer. There's a lot of different reasons for this, but one of the primary reasons is that we do have an aging population. Next slide. But there's good news to this story. The mortality rates have dropped significantly over the past several decades, and as it was already alluded to previously, there are a lot of different reasons for this. Certainly, we're doing a better job of tobacco control. We're detecting cancers much earlier, which makes them more easily treatable. But we're also making huge advances in terms of treatments, and you'll see that treatments change even on a monthly basis with new treatments coming out. So when we look at the 5-year age standardized relative, no, just go back. Sorry. Survival for all cancers, when you combine them all, the 5-year survival rate is around 2/3 of cancer, of people surviving, when you measure that from the date of diagnosis. But when you look at people who have survived their first year after cancer diagnosis, that increases to about 81%. And when we look at some of the more prevalent cancers, such as breast or prostate cancer, the 5-year survival rates get even higher, closer to 90%. So there is a good news story out of this. Next slide, please. But what I'd like to sort of highlight is that our cancer systems in our different provinces have historically been set up as acute care systems, which mean that what we do is we fund the diagnosis, screening and diagnosis for cancers and the treatment for cancer, but we typically don't fund in our healthcare systems the follow-up sort of rehabilitation and recovery for patients. So we certainly do cover surveillance, so following up with patients to ensure that their cancer hasn't come back. But in terms of the recovery, we're not systematically funding that. And as I said, part of it's just a historical thing where cancer was really more of an acute disease, and more often, if you look, say, 40 or 50 years ago, people didn't survive cancer, so that's the way it was funded. But as we've seen things change in the cancer field, the system hasn't really sort of moved along with that. When we think about cancer as more of a chronic disease now, one thing to highlight, though, that I think is important is that unlike other chronic diseases like diabetes or heart disease, where it's actually the disease process itself that causes disability in patients, cancer is a little bit different in that it's actually the treatments that we give to people that often cause the disability rather than the disease itself. Next slide, please. So there are a number of different challenges that cancer survivors face, and what I always like to highlight is sort of a shift, and this is coming actually from the World Health Organization. When you take more of a public health perspective, certainly mortality is a very important thing for us to think about, but we need to also consider disability, and from a World Health Organization perspective, disability is now considered as important as mortality. But I don't think that in the oncology field and in cancer, we have really sort of completely shifted to that way of thinking. So while the lots of advances in cancer detection and treatments have been made, and this has resulted in reductions in mortality, the long-term persistent and late effects of cancer treatments, we really need to do a better job of identifying those and also managing and treating and intervening for those. Next slide. So there are lots of different challenges facing cancer survivors, and we often sort of think about these in two different ways. So certainly during treatment, most patients will develop what we call acute side effects. So these are side effects from the treatments that you're getting. So I'll give an example of fatigue is a very common side effect that people will develop throughout their cancer treatment. So in some cases, you'll see up to 90% of patients developing fatigue during treatment, and it can be quite disabling. For most people, the majority of people, when treatment ends and a few months after that, the fatigue does subside and people start feeling better and getting back to normal. But there is a substantial minority of people, let's say I think the statistics are about 1/4 to 1/3 of patients who, for some reason, that fatigue does not seem to go away and it persists. So that would be an example of a persistent treatment effect. So something that happens while you're undergoing your treatment, which is acute, but then doesn't seem to go away. So that's a persistent treatment effect. And those persistent treatment effects, there are many of them, they can last for years or even decades after treatment. There's also something that we call late treatment effects, and these are side effects that may occur many years after treatment. So you might be going along your life and everything's going very well, and then all of a sudden you develop this. So a common example of this would be like a cardiotoxicity. So something happens where all of a sudden you develop a symptom related to your heart as a result of some of the treatments that you got that caused some damage. Now, persistent side effects, as I said, there are many of them. They are numerous and they are common. And actually, they often coexist, so you might see them sort of clustering together. So an example, going back to the fatigue, we often see if somebody has fatigue, they would often also have problems with insomnia or sleep. They may have, as a result, neurocognitive problems or difficulty concentrating, and sometimes people have anxiety or depression, and we would see that all sort of clustering together and exacerbating one another. We don't know the exact incidence or prevalence of these, although there are some studies coming out trying to track this. And really, it's hard to predict who's going to have persistent or late effects. So our knowledge around these is somewhat limited, although there are lots of researchers trying to figure this out and answer these questions for us. Can you move ahead, please? So just in terms of the physical side effects, I mean, certainly anybody who's been diagnosed with cancer or has a risk of a local or distant recurrence of their cancer or a second primary cancer. And so I think our systems do a pretty good job of monitoring for these. So you would go back and see your oncologist every, say, 3, 6, 12 months for your scans or tests to ensure that your cancer hasn't come back. But as I said, treatment can affect almost all of the different body systems and can result in these persistent long-term and late effects. And these can affect many different systems within your body. For example, we can see cardiac or respiratory dysfunction. People talk about having chemo fog or cognitive impairments. Pain is common. Fatigue is quite common. Neuropathies, which is sort of the tingling in your toes and fingers as a result of your chemotherapies. Many people talk about having functional limitations and being deconditioned, sleep disturbances, sexual dysfunction, and infertility. We know that these can be worsened by having other comorbidities, and in fact, about 2/3 of patients who are diagnosed with cancer enter the cancer system already with another comorbidity like diabetes or high blood pressure or those types of things. And so that just makes things a little bit harder. And certainly they can all be exacerbated by age-related processes. Next slide. So this is just a slide. It's not that new data. It's from 2003 from a study that was done in the States. And this I like this slide just because it's quite a large sample. So what they did in this study was they compared people who had a history of cancer. So those are the people in the gray versus people who had no history of cancer, and they were matched based on their age. And they looked at a number of different measures of health status and disability. And so what you can see is the patients the participants who had a cancer history had much higher rates of rating sort of poor or fair health, had more limitations of their activities of daily living and functional limitations, and a higher percentage were unable to work. So this just sort of highlights some of the more sort of impairments, how the impairments related to their cancer lead to sort of different impairments in their daily living and in their functional capacity. Next slide, please. And so in addition, though, to the physical impairments that people may experience, we also know that patients and their families also face significant psychosocial and economic consequences due to diagnosis of cancer and the treatments. I would say probably one of the most common side effects, psychosocial side effects that we see with cancer survivors post-treatment is fear of cancer recurrence. I think it would be, I think it's fairly common and not an unusual response to be afraid that your cancer would be coming back. We see this very often, and especially when people are coming up to their follow-up appointments, they get a little feeling anxious about what's going to happen. Am I going to be clear? Is everything going to be okay? But in some cases, this fear or anxiety becomes quite overwhelming for people, and it interferes with their ability to sort of do other things. It sort of is an all-encompassing fear or anxiety. So that is quite common, actually. Lots of people describe feelings of uncertainty or feelings of anger and anxiety, this emotional vulnerability. There are also issues around sexual dysfunction and altered body image. And there's also certainly changes in social outcomes, changes with relationships and communication or ability to function within their community, and lots of practical concerns related to getting back to work or school and health and life insurance implications. And even though we have a healthcare system that's funded where you're not having to pay to go see your doctors or those types of things, there are lots of out-of-pocket costs for cancer patients. So there are financial issues. Next slide. So about just over 10 years ago, the Institute of Medicine in the United States came out with a report called From Cancer Patient to Cancer Survivor. It was quite a comprehensive report, and really what they were trying to highlight is this growing number of cancer survivors that we're seeing in North America, and how our healthcare system hasn't been set up to address the needs of these patients. And the subtitle is Lost in Transition, and how patients are getting lost in that transition from active care to follow-up care. And they've really highlighted in this report sort of 4 essential elements, essential components of survivorship care, which include surveillance, which I think we do a pretty good job of, so surveillance for cancer spread and recurrence or second cancers, but also 3 other things that I probably would say that we're not doing the greatest job at. So one is coordination of care, so coordinating between all of the different medical practitioners that you're dealing with and specialists that you're dealing with, including primary care, prevention of recurrence and prevention of new cancers and other late effects. So a lot of that is around sort of behavioral and lifestyle interventions to prevent these things. And then finally, interventions and developing effective and cost-effective and sustainable interventions for cancer survivors to address the consequences, so addressing those persistent late effects of cancer treatments. Next slide, please. And so more recently, cancer rehabilitation was something that was proposed back in the 70s, and gained in the States, really gained a bit of a momentum at that time, but then it never really sort of caught fire and took off, and part of that was likely due to the funding. But it's over the last, I would say, decade, with this growing number of survivors, that there's been sort of a renewed interest in this model of using cancer rehabilitation as a model to help fill a gap in survivorship care between the sort of screening and surveillance and referral focus of our follow-up care, to deal with some of the specialized physical and mental health recovery. And so if you can go to the next slide, please. So this was actually an article, and I really like this quote that I've taken out of this article, because I think it highlights the reason why we need cancer rehabilitation. So it says, the experience of entering the medical system for many cancer patients is that they feel very good at the beginning, and then the treatments make them profoundly ill and often disabled. When they are sicker and more debilitated than they have ever been, they are discharged to follow-up care, which may include such things as routine screening for cancer recurrence, managing ongoing medications, and others. But this does not generally include a multidisciplinary rehabilitation intervention. In effect, the medical system creates a situation where high-functioning individuals are given life-prolonging treatments and then left to struggle with how to recover from the toxic effects of these therapies. So I think this really highlights what the issue is here, and why we have moved to a cancer rehabilitation model and trying to advocate for that. Next slide, please. And so if we look at the literature that's out there, there are many different ways that cancer rehabilitation can help people. There are many different outcomes. We've seen in the literature that cancer rehabilitation and exercise interventions can help with pain and fatigue, deconditioning, mood disorders, and late effects such as heart disease and diabetes and those types of things. And this is a definition by Crome that's actually quite old, but I actually like it. I think for me, it's the best definition of what cancer rehabilitation is. So it says, cancer rehabilitation involves helping a person with cancer to help himself or herself obtain maximum physical, social, psychological, and vocational functioning within the limits imposed by disease and its treatment. So I think I'm going to switch it over to Stephanie now, because next slide is going to, can you go to the next slide just so I can see what it is? Yes, okay, good. So what I'd like to do now is sort of switch gears. I think this has provided a good background to sort of lead into why we have our program. And what Stephanie's going to do now is take over and describe what our program actually is here at Princess Margaret and what we're offering to our patients.
Great. Thank you, Jennifer. I think when we look at how we built our program, we really looked to the impairments in dealing with cancer treatment, and again, really trying to set up a team that would be supportive of patients, but also give them resources in the community or specialized programs. We know that we can't be everything to everyone, so sometimes the approach is to make it more consultative. It may involve just assessing a patient and then triaging them to the community, and working really well with community partners so that we can all really, the core aim is the patient's well-being and their experience in maximizing that. So on our team, we're very privileged to, you can see from the slide, we have a physiatrist, which is a doctor of physical medicine and rehabilitation, who also has experience dealing with cancer care, which is really unique. Dr. Eugene Chang is the first of his kind in Canada, and we are very privileged to have him provide medical support and lead to our team. We have physiotherapy, we have massage therapists who work with a lot of lymphedema patients. We have dietitian who definitely looks at someone's nutrition and their dietary needs, the effects of cancer on that change. We have a neuropsychologist, again, to deal with some of the brain fog concerns. We have occupational therapy, again, a lot of the issues around fatigue, return to work, day-to-day functioning, psychosocial components. We also have a social work and psychologist who, again, deal with some of the psychosocial distress. And within the last 2 years, we've also added a new member, a kinesiologist, which is healthcare providers with some specialization in cancer exercise as well. I guess the only one within nutrition I forgot to mention was a wellness chef. And researchers. I don't think, our program is unique in that we have clinical and research expertise in this field. I think a lot of patients who come through see the benefit of having all of these various different healthcare providers. Next slide, please. So it's a busy slide. We just wanted to outline a little bit of the flow process for patients that come through our program. So the oncologist, physician that refers a patient to our program, we screen the referral to just ensure that the criteria is appropriate. What that means is that their reason for referral is cancer-related impairment, that they're not referred to us because of tennis elbow, let's say, as an example, and that some component of their cancer treatment has occurred at Princess Margaret. They're being followed by an oncologist here. If those criteria are met, then we book them for a comprehensive assessment. This is done jointly with our physiatrist, either a physiotherapist or an occupational therapist. And our appointments are 2 hours long. Patients complete some patient-reported outcomes, so we get their perspective of what is of concern to them. And then we do a very detailed assessment, components including physical, functional, the social, the cognitive, and the emotional. I think sometimes we're the first place where we've asked someone about the impact on their sexual health and intimacy. A lot of patients feel like that's an area that gets neglected. So we try to really appreciate all facets of a person and to look at them holistically and really get a bigger picture of how they functioned prior to their cancer treatment, the impact of the treatment, and what their needs are currently. And the goal of this assessment really is to work collaboratively with the patient at the center and the healthcare team, supporting that patient to arrive at a care plan that, again, identifies these needs and what is the best support to help this patient. So from there, we look at the needs. If it's a lower need in terms of the impairment level, as I mentioned earlier, we try to triage patients to the community programs for wellness. We don't have the resource to see everybody, and it's not to our best interest to do something that's done very well in the community. So we have very strong partnerships with community cancer organizations such as Wellspring, Gilda's Club. We also offer some wellness programming at ELLICSR, which we'll talk to a little bit later in the presentation. And then there are other programmings in the hospital and outside that also meet some of these needs. On the opposite stream, for someone who has very high impairment, maybe they're limited by pain or they have some physical musculoskeletal conditions that they're not quite ready for a group-based program. Through our services, we may refer them to more specializations such as cancer pain clinic, might be the musculoskeletal oncology program at Toronto Rehab, where they provide more hands-on manual skills technique with physiotherapy and occupational therapy. Sometimes patients live very far from the center, and it makes the most sense to connect them to services locally or through the LIN, previously called the CCAC. And sometimes they have benefits that they can utilize some supports in the community as well. Where we try to focus our services is on that moderate spectrum of impairment, and where patients are deconditioned, as Jennifer mentioned, but they also have other concerns like fatigue, maybe brain fog, maybe they're eating not as well as they did before, they're having trouble sleeping, they're having trouble coping emotionally. So this cluster of symptoms, and it's affecting their day-to-day functioning moderately. So this is the core group of patients that we try to see within our program, where we have a group-based cancer rehab and exercise program. Next slide, please. So just to get into some of the specialized therapy and consults that run parallel to some of the group-based activities that we offer, lymphedema is still probably one of our biggest reason for referral, and we know it's one of the main late effects of cancer treatment. So patients with lymphedema get education, they get assessment with measurements of the affected limb, they learn lymphatic self-massage with our complete decongestive therapist who's a massage therapist. We may teach them self-bandaging, talk to them about the importance of exercise, put them with support from a psychosocial perspective, connecting with other patients as well. These happen in a group as well as one-to-one follow-up. And then you can see the rest is just a sampling of other topics where we may focus as a highlight on return to work, because that is a big impact of cancer. They will meet with our occupational therapist and prepare a return to work plan that supports them to return to work safely and productively. We have a sexual health therapist, which is also unique to our program, who's a pelvic floor therapist and can see patients individually and provide some recommendations. And then nutrition, neurocognitive, social work, and physiotherapy follow-up as well, just some samples. Next slide, please. So what is unique about our program as well is that we are the first of our kind in creating a group-based cancer rehab and exercise program. It is 8 weeks long, so patients who that we identified through our comprehensive assessment would be a good candidate for this program. They then meet with a kinesiologist, and they have a physical fitness assessment and exercise prescription. So everyone gets an individualized program based on their need and based on their goals. premise behind this is obviously the research that supports the value of exercise, but also targeting some of the lifestyle changes that we know would be helpful to help patients recover from cancer, help them maximize their quality of life. So each week, their patients come and it's done in a group, usually around 8 to 9 patients. They have an hour of exercise that's facilitated by a physiotherapist and a kinesiologist. And then each week there's an education topic that you see there. How we came up with this is we actually surveyed patients to ask them in terms of dealing with their cancer treatment and its side effects, what are topics that are important to them. So we had patient feedback, married that with our team's expertise and informed by the literature. We created parallel education sessions that deal with fatigue, managing difficult emotions, being mindful and relaxation techniques, eating and cooking for wellness, the importance of social connectedness, as well as brain health. And then there's a graduation at week 8 where patients are reassessed by their kinesiologist for a physical fitness test, just to show them the progress and change that they have made in the 8 weeks. And beyond this, patients are also reassessed once again at 3 months and 6 months, again, just to see how far they've come along, as well as any ongoing support that they may need from the community. And usually at this point, at the 6-month mark, we discharge patients or else route them elsewhere. Next slide, please. So just to share with you over some of our kind of stats over the past 3 years since we've kind of implemented some of the changes to our clinic, including this 8-week group-based program, we've definitely also had an increase in our patient referral to our program. Now that we see all cancer patients, it's increased by close to 30% in terms of volume. So we are learning a lot from some of these newer sites as well. In general, each month we get between 80 to 100 new patients referred to us from all the disease sites at Princess Margaret, and we do about 2,000 follow-up visits per year. So some of these are some of those specialized follow-ups. Because really there isn't a lot of places to send these patients into the community, unfortunately. And as I mentioned, opening our doors to all cancer site groups has been wonderful just to increase access, but at the same time, it's been challenging to learn the needs of so many different site groups. So it's been wonderful learning from our staff and from the patients that we see. And we, again, are lucky to have Dr. Chang as medical lead to support us as we're seeing some of these more medically complex patients. Next slide, please. And some of the key reasons for referral to our program, you can see at the bottom is a whole range, but the top 3 are really around fatigue, musculoskeletal concerns. So some of this includes that they've had decreased range of motion, they may have pain through a joint, decreased weakness, sometimes could be other things related to just the functioning because of these limitations. And a lot of the patients are deconditioned. They're in need of exercise, program, and counseling. Next slide, please. And just coming back to Jennifer's point around disability, as part of our program, some of the outcomes that we do collect is looking at disability. We use the World Health Organization Disability Assessment System, the WHODAS-2, as an outcome measure for disability. And we can see that for patients that have come through our care program at ELLICSR and care program at home, at facility-based, 92% have moderate to high degree of disability, and for those who come through the home stream, 79%. So again, speaks to Jennifer's point earlier around the consequence or the impact of cancer-related impairment in terms of disability and functioning for our patients, and the importance of having cancer rehab. Next slide, please. We've also had some participant satisfaction and feedback that have come through our group, and you can see almost 100% of patients reported that they were glad that they participated in the program. They felt that the program and was the atmosphere, the staff was very supportive and encouraging, and that they would recommend this program to other patients. Next slide, please. these are some of the testimonials that we have. I think one of them, I'll let you read it for yourself, but while you do that, I'll just share one of the biggest, sometimes hidden gems from the group-based program is that patients have the opportunity to actually connect with other cancer patients, and they know that they're not alone in experiencing some of the side effects and late effects of treatment. Learning and sharing with each other really has been supportive. Many of the groups after graduation continue in an informal way to still gather together because they've connected with each other and have supported each other. The other point I think I want to highlight is just the comprehensiveness of the program. This is ongoing feedback that we get from our patients who come through. They just feel like we've recognized them holistically, and we've addressed the physical, the emotional, the cognitive, the vocational concerns, and really equally as well, the education strategies has been equally important as the exercise. So it really speaks to just how much patients get from this program. Next slide, please. And next, I'd like to just highlight a little bit, as I mentioned at the beginning, within ELLICSR, we do have a wellness programming as well that we support patients through. So the one that we have in-house is Healthy Steps. It's a gentle exercise programming set to music. It's very fun, again, building a sense of community. We also partner very well with our partners at Gilda's Club to deliver yoga, to deliver mindfulness, art for cancer, Tai Chi. So we're trying to, again, be informed by the literature and bringing programs here. Tai Chi is also a study that we've offered at ELLICSR called Match Study with Tai Chi as well as mindfulness. Next slide, please. And again, I think we're unique in the sense that we have a beautiful kitchen and a wellness chef and a dietitian who work very uniquely within our program. It's very innovative. It's teaching patients, caregivers that support them about importance of eating and cooking for wellness. All the recipes that are created are vetted by our dietitian. We have demonstration videos, as you can see, a total of 363. It's also been a very popular subscriber to YouTube channel for ELLICSR Kitchen, and it continues to support patients as a resource for recipes, for tips and strategies in terms of managing side effects of cancer treatment as well. I'll pass it back to Jennifer now, if we can advance to the next slide.
Yeah, and I'll encourage people to visit the ELLICSR Kitchen website because it is a wonderful resource that people from around the world have accessed. We've had over 4 million views of our different videos, so it is pretty popular. Today we had a class, and people are actually welcome to come to ELLICSR. If you're in Toronto, it's in the Toronto General. This is our health and wellness center, the ELLICSR Center, where we run our cancer rehab programming, but also our wellness programming, which is available to anybody. People can just come in and take part in a kitchen class and those types of things. You don't need a referral for those. And today we had one actually, it's just finishing up, I believe, and the topic was on managing taste changes. So it is focused on trying to help people manage different side effects with nutrition, and we have a wellness chef who makes the food very tasty and lots of culinary tips and things, which is great. So I just want to finish, because we do want to have a couple minutes at the end for questions. So I'd like to just finish talking about some of our future directives over the next year or so. So one of the things that we have been working on over the past year and a half is trying to adapt our 8-week care program that Stephanie talked about. So that's our 8-week program that people come in and do the exercise and the classes to a supported virtual home-based program. So what we've done is we've built, taken all the classes that we offer over the 8 weeks and built modules, interactive, they're beautiful interactive electronic modules. And we're building now the platform, and later in this fall we'll be launching this program. So patients that get referred to us and who are eligible for the care program and who are unable to come to an in-person 8-week program, which is, I would say, probably 40 to 50% of our patients, because they live very far away and it's hard for them to come, or the cost of coming downtown, or they're back working part-time or have children, whatever the barriers are. There's lots of barriers for not being able to do that. We'll be able to have this program delivered to them at home, and they can sort of do it at their own pace, although it is sort of structured 8 weeks, so they have to do a module a week. But there'll be the exercise component will be built in too, and they'll have remote support with our team, so the team will check in with them each week to see how they're doing. So we're really excited about this, and we are piloting this with a grant that we got through CCO. We've done user testing of the modules that we did this summer, and now we're just revising those, and we'll be launching in the fall with a pilot project here, and I look forward to sharing. Actually, it would be great. This could be another webinar in the future to share results from that with you. And the great thing about this is that hopefully this is something that can be scalable in the future, that other centers could take advantage of, and we are always happy to share what we do here at Princess Margaret with other programs and see what can be scalable. Next slide, please. The other thing that we're really interested in is because we've increasingly seen patients that have metastatic disease getting referred into our program to deal with some of the symptoms and impairments that they have. But the other thing with the palliative program here at Princess Margaret is that there's been a big push to try to get patients referred into palliative care services earlier on in the as soon as they're sort of diagnosed with metastatic disease, to get them referred and connected with the supportive services that palliative care can provide. But at the same time, there's not really much that has to be done or that can be offered at that time if people aren't really super symptomatic at that point. And so we started thinking about our 8-week program and how we might be able to adapt that to meet the needs of patients that have metastatic disease. Because a lot of the things that we cover in our 8-week program would be really applicable and I think quite helpful for patients that have metastatic disease. So this summer we did a survey of patients who were coming to the palliative care clinic at Princess Margaret. So we did a survey with one of our wonderful summer students came in, a nice, keen, eager, happy person came in and did a survey with 60 patients in the unit over the month of July. And this data is going to help to inform what we need to do to change our curriculum and maybe supplement and add some modules. For example, pain came out as something that was really important, and we don't have a module on that or a class on that yet, so we'll need to develop one. So all of this data will help us, and so that will be another thing that we're going to try to focus on in the next year is seeing how we can adapt our 8-week care program to have a stream for patients that have metastatic disease. Next slide. And our final slide is I'm really happy to announce that as Stephanie mentioned, we have a physiatrist, Dr. Eugene Chang, who did his own fellowship in cancer rehab at MD Anderson in the States. And he went there because there wasn't a cancer rehabilitation fellowship here in Canada. And so when he came to Princess Margaret, that was something that was really important for him that he wanted to try to develop here at Princess Margaret. And so over the past couple of years, he's worked hard with his foundation, our program, and with Toronto Rehab to develop this fellowship. So this is Canada's first fellowship specifically in cancer rehabilitation for people who have finished their residency in rehabilitation medicine. And our first fellow, David Lanchelaer, started this July and has started his fellowship with us. We're very pleased to have David join our team. And the idea is that this will be something that will happen every year. So each year we'll bring in a new fellow or two and build capacity across Canada. And hopefully these fellows can go out and build programs in other centers as well. So I think that's our last slide. You can go to the next slide. Yeah, so thank you. So we are very happy to answer any questions. I do want to just comment, though, because many of you might be wondering, where do they get the funding for this fantastic program? And I do want to acknowledge that our program is funded completely through the Princess Margaret Cancer Foundation. So that's the Princess Margaret Foundation. We do not get funding through our ministry, although Dr. Chang, who is a medical doctor, is able to bill OHIP. So his funding does come through the OHIP billing, but everybody else in our team is funded through our foundation. So, questions?
All right, so thanks once again to Dr. Jennifer Jones and Stephanie Phan for that fantastic presentation. I know a lot of individuals leading up to this webinar expressed, frustration and confusion as to the state of cancer rehabilitation in Canada, and your program is one of the best, is my understanding, in the world, and the only one of its kind in Canada. So it's great to have that baseline of what's offered at Princess Margaret. We do have a couple of questions coming in here, and just a reminder to everyone, we do have a little bit of time here for questions. So if you still have a burning question on your mind, there is time. You can type your question into the panel that should be on the right-hand side of your screen, and we'll address as many as we can here. Interestingly enough, the first quote-unquote question that came through was actually just kind of a story from one of our attendees about her treatment process over a number of years, and the frustration in not having rehabilitation, just kind of sharing her story with us. I won't go into it in detail, but definitely experiencing frustration at the lack of cancer rehabilitation. But she did follow up later with a second statement just saying how impressed she is with the follow-up programs at Princess Margaret, and says that statement that we agree with, that this needs to be Canada-wide, and what can be done to try and push for this much-needed survivor program.
Yeah, so I mean, I would 100% agree with that statement. This is not, it shouldn't be something that just happens at Princess Margaret. And anytime I present this anywhere, people are always asking me, well, why is it only available to patients at Princess Margaret? So one of the things that I think about as being the director of the program is that I feel that, we've been, through our foundation, we're very lucky to have this program. And to me, I don't take that for granted in any way. And so I also feel at the same time we have a responsibility to advocate for all cancer survivors and to take advantage of the infrastructure and support that we have here to do that. So as a researcher as well, everything that we do with our program, we collect data. We consent patients and ask them if they're willing to take part in research, and we track how we do and the impact of our program. And we're hoping to, have quite a large database to help that we can then use that data to really try to make the case for the need for these types of programs. So, I mean, as much as possible, through these types of forums, going to, these government caucus meetings that you've talked about, we try to advocate for this type of thing.
Yeah, absolutely. And on behalf of CCSN, I'll add on to that, to that attendee who asked those questions, we will contact you directly after this webinar just to share some of those initiatives with you if you do want to take part on a larger scale or know anybody else who would. And that does go for everyone attending this webinar, that, our initiative, we have a lot of initiatives going on that we welcome patients, concerned individuals to take part in. So we will follow up with that as well. It's a great question, and definitely this needs to be in more places. So we have two other questions that are kind of similar, just kind of asking about specific rehabilitation. One asks that his wife was a year ago diagnosed with multiple myeloma, and she's quite fit, but walking makes her spine worse because her trunk muscles aren't strengthened enough. And is there rehab programs for kind of improving the spine and preventing further fractures, is the question.
Yeah, those are really good questions. Anytime we prescribe any exercise, it's very important that we rule out any risk factors such as that or just risk of that, especially with multiple myeloma. That's why it's important to, within our program, we have Dr. Kang, we have his support in terms of giving medical clearance, and then precautions for certain exercises are taken into consideration when prescribing these exercises by physiotherapists or our kinesiologists. I think one of the best things we can do is minimize harm at the very least. So it's always good to have better guidelines with regards to precautions for exercise, seeking medical clearance whenever it's necessary prior to cancer patients doing exercise, especially if they're higher risk. So I'm not going to go into specific details, but the importance of kind of working with your doctor to get clearance prescribe any precautions relating to exercise, and then working as a team to come up with exercises that take into consideration.
Yeah, thanks so much for that. Great question. Another one here, sort of on a similar vein, are there any initiatives in place to ensure physiotherapists, chiropractors, massage therapists, et cetera, are aware of the physical impacts that, in specific here, we talk about breast cancer surgery, physical impact breast cancer surgery has on patients. This person is an ex-respiratory therapist who's been fitting bras and breast prosthetics for 28 years, constantly assisting people with their posture, because the muscular pain they can experience from lack of symmetry can be astounding. So they're wondering about how can, are there initiatives in place to ensure that other medical professionals can be aware of the impact?
Yeah, I think that's, again, a larger question. To me, it stems more systemically to training. And I know a lot of work has been done. I can speak personally from an occupational therapy perspective, and I think similarly in physiotherapy, in terms of training programs for these healthcare providers or kinesiologists, or again, any healthcare provider that works with cancer patients. I think at the curriculum level, they need more instruction on cancer rehab. And again, what are these side effects? What are the implications? What are precautions that need to take into consideration? So I know that we have to work very strongly and advocate at the university level, the entry level, to provide these education to healthcare providers coming out equally with, I think, on a different front with doctors, right? They probably don't get enough around the importance of exercise and nutrition and other aspects of lifestyle factors. So I think at the kind of educational level, we need to continue to work more closely with the coordinators to ensure that that level of education is provided.
And I mean, we've definitely identified this as a gap, and the need to expand capacity and expertise in the community. So, right now it's really difficult for us to refer patients to people in the community because, people aren't completely comfortable treating patients that have had cancer. So we've been talking about developing some training programs and sort of a institute here, a training institute to do that. But there isn't anything formally in place. I know the kinesiologists do have a course. So there are things that are getting developed slowly.
Yeah, great answer. Thank you. I know it's not an easy question to answer by any stretch of the imagination, but it's progress is in place. Following that, we have a couple of just kind of statements I'd like to share. One woman said, "Sorry to have to sign off early. The program being described is excellent. Commendation to Princess Margaret and ELLICSR for the progressive work you've been doing. Thank you for the presentation." Another one here, "Very good presentation. I've been a participant of the ACE program in Alberta, offered by Margie McNeely, who we spoke about earlier. She was in attendance at our Alberta caucus, and it has been a lifesaver. Strongly support this program. So thank you for your statements. That's fantastic." Another one here, just one second. There we go. "I'm in New Brunswick and look forward to hearing more. We do have a Stay Strong program in St. John, but it's only available to the newly diagnosed. I'm a 7-year survivor and on the board for the New Brunswick Breast Cancer Network. We host a wellness weekend in November, which I look forward to sharing some of this info, like ELLICSR's Kitchen. These ladies feel very forgotten post-treatment." Thank you so much for that statement. What you guys are doing is fantastic. And definitely pass along these fantastic resources. And we just have a couple more coming in here. Oh, and there's an important statement here as well that in terms of lymphedema, an attendee has posted, "Just want to make today's participants aware of the resources of the Canadian Lymphedema Framework. Their website is www.canadalymph.ca, and we have referred their website a number of times, and it is a fantastic educational resource for lymphedema. So just a reminder to everybody that also exists."
Yeah. Yeah. I mean, there are many great programs. Certainly, lots of community-based programs. I mean, we're aware of the ones here in Toronto, but I know across in Hamilton, across Ontario, and then across Canada, there are a number of different, community-based programs, and then some rehabilitation services, and certainly in lymphedema. services that are growing, which is it's fantastic. And we certainly base a lot of the work we do on the lymphedema framework as well.
Absolutely.
Mm-hmm. Yeah, for sure. So definitely if you're struggling with problems with lymphedema, definitely check out that resource if you haven't already. And with that, we're past 2 p.m., so I'm going to go ahead and finish off here. If you guys have any additional questions that you're just not thinking of right now or you want to address individually, please feel free to send us an email to info@survivornet.ca, and we'll get you in contact with Jennifer and Stephanie, and we can follow up from there. And from there, we'll conclude